I want to just mention a couple of things. It's approximately 5 to 6 centimeters that we measured it, right? Yeah, close to 5 centimeters from what we measured before. As you can see, it has a shell or a wall that is definitely more hyperechoic than the rest of it. The content of the lesion has variable echogenicity. Some of it is hyperechoic, some hypo, some anechoic completely, as you can see. We could not identify any remnant of the pancreas, so this must have been a pretty significant necrotizing pancreatitis.
Yeah, that's true.
Yes, at least to what we can piece it together. And this lesion to us looks interesting. If I have to guess, I would say this is very dense necrosis that has been slowly shrinking for the last 3 years, and finally now it looks like a mass, although I think we get, obviously, it's adherent to the gastric wall. As you can see, there isn't a lot of distance. It's actually kind of, in a way, stuck on the exterior gastric wall. So I think, so some benign lymph nodes around it, as you can see.
It could be inflammatory as well.
Right. So the next step we're debating is sampling it. What do you think?
Yeah, sure. But we need tissue. Tissue is the issue. So
Yes, let's get some tissue.
Yes. Great illustration. Would you consider doing a contrast-enhanced EUS in these cases where you doubt if this is a viable tissue or necrosis?
Definitely it would be helpful, because if it is any net or any tumor, definitely it will light up the contrast and whether it's a dead thing or it's a well perfused. So of course.
What's interesting is that you see a very well-defined wall to the cyst right there, which makes me think this is a shelled out, completely compartmentalized type of necrosis.
It is too well-defined to be a tumor.
Too well-defined, correct, to be a tumor. I think someone asked, could this be an exophytic gist? Yes, gysts can be exophytic. I think we need to rule this out. I usually don't see a shell or a wall around gysts. So there's one area where Dr. Emad was asking is, does this extend beyond right there? So I think what we're seeing is...
I think there is a wall there as well, you know?
Yeah, there's definitely a wall.
Yeah.
So if we tore...
It's a tangential...
Yeah, this is just tangential. It could be, right, this could be a remnant of the pancreas itself. Although we're not seeing anything else besides that collection at this point. So yeah, this is definitely something we want to sample. So the question is, if we think it's solid, we should do an FNB.
Yeah.
If we think it's thick liquid, we should probably do an FNA, maybe 19 gauge FNA.
I think if you put in FNB, it will give us...
so we have a 22 Acquire, has a Francine tip, superb tissue acquisition capabilities, and Dr. Emad is right here next to me, getting ready to help us out with it.
So, Dr. Haddad, what is the size of the cyst? What is the size and where it is regarding to the PD and the CBD? This is in the head, right?
Have not been, it's actually, no, it's in the tail, body and tail. We believe the cyst replaced the body and tail completely. We could not identify any remnant of the pancreas. And it's approximately 5 centimeters, 5 to 6 centimeters.
Yeah, so I mean, by the look, it looked like solid lesion. However, I agree, by the history, it was 12 centimeter 3 years ago, and now 6 centimeter. Yes. So I think it's basically a collection that regressing in size. But I mean, the density going also with solid, so we probably would know this by sticking a needle and aspirate, and we'll see if anything comes out.
So, which brings us actually to the different techniques in performing fine needle, whether you like to do it with suction, without suction, slow, stylus pull, what's your approach?
So, what I would feel that whenever you're sticking a needle into any lesion, it's best to do a Doppler. You know, it's always good to see, because sometimes you can have surprises. There is a vessel passing by, and you don't want to go through them, especially if you're doing any therapeutic procedure, cytosis drainage or something. It's always good to have a needle. And regarding the approach, traditionally, most of the people like suction, but a lot of people, they don't want suction. It depends where are you hitting at. If it's a lymph node, if you put suction, it can be a disaster. You can have a lot of bleeding there. But as I think they demonstrated earlier, slow pull is a thing of choice. I think most of the people are comfortable with it. So in my practice, I follow a slow pull technique for thing.
So
Alhaddad, what do you?
Yes.
I will help you with that.
Yeah,
so
I
Emad,
agree that
if
it's
we
slow
can
pull,
have,
especially
can
you
we
don't
have
know
a
what consistency.
Doppler ultrasound just to check this
Yeah,
hypoechogenicity,
let's
the
see if we can,
anechoic structure is
still
not a
kind of getting
vessel.
used to the
Yeah,
system.
exactly. We are not. Good. So,
Good.
so this looks clear to me.
Yeah.
So if you guys give me go ahead, I'll go in and
Yeah.
yeah.
So it's really
Yeah,
nice.
I think it's
put it
clear.
on
Yes,
an acute
absolutely.
angle,
Yeah.
not having the needle actually in an acute angle, which can increase the chances of not hitting the target and
Right.
slipping. Very good
Beautiful.
demonstration also. Yeah. Also
I
that
think
you're
we can
passing reversing
get
voltage.
it off Doppler because it always interferes with your vision. So I'd request you to push in the stylet. So I think it's a good idea to push the stylet so that if anything is sticking into the needle as we are going to the mucosa, so you can remove that. And then, of course, I will keep on moving the needle and Dr. Emad will keep on pulling the stylet slowly to help me. That's the slow pull technique, and it's always good to fan, so you can use the elevator and the big wheel to go through the different
Yeah,
portions.
it's a very
so that
nice
if it's a
fanning
tumor, you can
demonstration.
always-
So
If the
what is your
cameraman could help
differential?
us in pointing down how we do the slow pull motion. As a matter of fact, what we do, what I do is basically I pull the needle, keep the stylet in place while he's advancing the needle. So that will create a vacuum or space for more tissue to be collected through the needle. And any specific passes that you would perform at a single sit.
Okay, so another thing is that this slow pull, what it will do, it will act like a capillary. So it, like he's making a space, and with the capillary, the tissue will keep on going inside. And regarding the actuations, what Dr. Emad means that you have to, how many times you will pass in one pass. So this, there's no fixed number, but usually more than 12 to 15 actuations is what we aim for, so that we have adequate tissue with us, so that you have.
So what I
enough
do is
air.
basically, if I want to illustrate this, I put my finger here. So that's how I keep the space.
Gradually pulling it.
So from the
So I
look,
don't actively pull. I just remove it
Yeah.
slowly.
So Emad, we have a
Very nice.
question here. Your differential diagnosis in this case.
so it was 2 centimeter and now it is 6 centimeter. It's a solid lesion, rounded,
No, just for now, just
occupying the body and the tail. What is your differential from the EUS?
So the first, see, it looks like well-defined, Dr. Alhaddad said. Another thing is that it looks more solid now. So
demonstrate
it's
that, yeah.
almost like a solid tissue. And so since he has a past history of pancreatitis, and it was 12 centimeter, it became smaller. So the tumor unlikely shrank. So the first differential is it's some collection, maybe pseudocyst, which got organized, and it is more of a post-pancreatic collection, I would say, which is
Yougsh?
almost solid now. And
Yougsh?
of course, second is maybe a tumor, could be a gist or NET or something like that, which also could be there. So I think
Yougsh?
We have a questions from the audience, Dr. Nadeem.
Yougsh have brought a message, no question, no comment. Could it be a net? Khalid says so.
How we actually collect the sample and put it in the bottle. Where is the container?
right here.
Okay, if you can bring it over. Right
So the camera could.
there. I can't see them. I'm sorry. I'm gonna get this. So if if everybody pays attention, I'm going to show you how do we actually put the sample in the container after we obtain it using the fine needle aspiration or biopsy. So simply what you need to do is put the needle out for about 1 centimeter, like that. While the stylet is in place, you just push it in, like that. And you can see the tissue being dropped into the container. And if that doesn't happen, or even if it happens, you can see
There we
that
go.
a
It's
little
coming
bit.
through.
Yeah, and I'm gonna, sorry, I'm gonna fix this. We're gonna pull it, and then use
Flush
flushing,
it with
yes,
a syringe,
to
yeah.
push whatever is remaining inside the channel of the needle, like that. Or air, whatever you want to do.
Yeah. So I think with this nice fanning and negative slow pull technique, and with this small amount of tissue, I think this is more like a debris inside, and it's a collection of dense fluid rather than solid lesion.
عادل
Okay, another thing I would like to show for the beginners or the fellows in the auditorium is how do you do the FNA. So you tighten or fix the needle, and this is the sheath. So you.
So yeah,
have to
if you
bring out
don't
the sheath
mind,
first
so
to protect-
yeah, we will have 1 minute if you can demonstrate, and then we'll conclude. So yeah, go ahead.
Thank you.
Yeah, okay. So you fix the sheath first to protect your scope. You see the sheath coming out. They're like two parallel solid things. And then initially, a lot of the people, they want to fix the needle so that you don't cross the lesion. If there's a vessel beyond or there's another organ, you don't damage it. But the experienced people like Emad or Dr. Alhaddad, they don't need to do that. And then you just give a jab.
Yeah, there we go. That's
Strong
beautiful.
grab, and then this time maybe we'll use negative pressure suction.
Yeah.
Because
So
I
so
think we're
so that's
probably
a
going
great.
to
I may
the
just add that the first step when you see the stylet is out called sharpening, just to make the needle sharp, and then you can push actually the stylet in to get any contamination away, and then you start to pull it back. And this is the negative suction. If you can open the suction so we just can see before we conclude the session,
It's already
please.
open.
Yeah.
Yeah, I suspect it's too thick to show up in the syringe. However,
it's
when
already
we
open.
express
Yeah,
it,
yeah,
it'll
for
come out
sure.
as
Yeah.
white, curd-like necrotic tissue.
Yeah,
I'm gonna
I
make a
think
bit
it's
of
yeah,
this.
probably
I feel
it's more like a debris.